Welcome back, everyone. Really excited to introduce our two speakers who are incredibly gifted physicians and experts in long-term care. First, Dr. Ruth Spinner. She is a senior medical director at the New Jewish Home and a clinical associate professor in the Department of Geriatric and Palliative Medicine at the Icahn School of Medicine. She's involved in clinical and quality improvement, as well as medical education for students and geriatric fellow trainees. She has published numerous articles and peer-reviewed articles and is the past recipient of the United Hospital Fund 2001 Excellence in Healthcare Award for Quality Improvement Champions and of Leading Age, New York's James W. Sanderson Memorial Award for Leadership. Joining her is Dr. Jeffrey Farber. He is the president and CEO of the New Jewish Home in New York, and this is a nonprofit health system providing not only short stay rehabilitation, but skilled nursing and community-based programs. Prior to being the CEO, he has served as the CMO and Senior Vice President in Population Health at the Mount Sinai Health System. He is professor of the Department of Geriatrics and Palliative Medicine at the Icahn School of Medicine. His research interests are models of care for older adults, population health management, and the clinical interface with healthcare finance. He's a national recognized speaker, has been twice funded through federal grants, through the Health Research and Services Administration, and as well as his GACA Career Award. He has published his research in numerous journals, high impact journals, Annals of Internal Medicine, JAMA Internal Medicine, Journal of Hospital Medicine, and JAMDA as well. And he runs a really innovative program called Skill Spring, which is training for young adults and youth under-resourced community become certified nursing assistants. And we're really excited because both of them are going to talk about a topic really dear to my heart around clinical quality in the nursing home. And we're going to learn so much from them. Jeff and Ruth, thank you for being here today.
Thank you, Helen. It's a pleasure, and welcome everybody to your Understand Beginning first part of the final day of the CME course. So thank you for being with us. I will commit to making sure that we've got time at the end for questions, which we would love to entertain and discuss. And so therefore, I'm just going to jump right in and then turn it over to Ruth. We're going to review, and I think, for the broad audience, what we think is most important for everybody, even those that are not focusing their careers, of course, on long-term care, to understand in the field. And that's overall a preview. I'm going to do an intro to the nursing home star rating system. We could talk and in questions and answers about how problematic it is, but it is, and a lot of people, easily access it and base decisions on it. The nursing home quality score, which really does aim to measure quality both in long-term care and short-term rehab, and focus on a couple of specific measures that Ruth's going to get into a lot of detail, and also clinical management and best practice, in long-term care for managing conditions and avoiding rehospitalizations. So I'm assuming everybody's seen this like CMS 5-star rating, and if you haven't, it's really easy to do. Just type in nursing home compare on any web browser, or CMS nursing home compare, and you'll get the website. You could put in a zip code, you could put in a name. It's easy to actually use, and then you can find all this information. But I want to explain a bit how, it works. How do you get those star ratings in the end? So prominent on the page and what's most visible is your overall star rating. And the overall star rating is actually comprised of 3 different star ratings, and each one you can also see on the website. It starts with the health inspection, otherwise called a survey. And recent changes, new from last year when we spoke about this, is that they've compressed and utilized only the 2 most recent surveys instead of the prior 3, and they've added the prior 3 years worth of complaint or infection surveys. So in other words, generally speaking, the feds outsource surveys to the states. Usually CMS, right, outsources it to departments of health in every state, and the Department of Health has surveyors that they either employ directly or contract out to another third party, and they come on site and they do surveys. They're supposed to survey once a year. Mostly they're behind, in New York, particularly behind. And then in addition to sort of the results of that survey, there are opportunity is not the great word, but incidents throughout the time where anybody can register a complaint that gets investigated and or self-report. There's a lot of self-report requirements, and you can also have star related health inspection points related to those things. So you have the points that accumulate from the survey itself on site, in person, and then every day things happen. So that's the health inspection survey. And then you have a staffing survey, which is relatively new, and they report on staffing levels and retention rates. And we have to all submit what's called payroll-based journaling. PBJ sort of reports on a constant basis to CMS, so they know exactly how many nurses, how many CNAs, how many LPNs, per shift, what was the census, every unit, fairly complicated and onerous. And then the quality measures, which we'll spend more time on, of which there's 15 total. So you start with that health inspection score, and that's basically your score. It could either go up one if you have a 5-star in the quality, or it can go up one if you have a 5-star in the staffing, or it could go down one if you have a 1-star in the quality or a 1-star in the staffing. That's really how it works. So you start with, and this is like kind of from the website, the health inspection score, let's say it was a 3. And then if your quality is a 5, that means it adds 1. So now you're at a 4. And if your staffing is neither a 1, which would make it therefore a 3, or a 5, which would make it therefore a 5, it stays the same, and your overall quality in this case is 4. So just an example to kind of walk you through it. Now, this is sort of the way it works. In health inspection, points are bad, right? So the more higher number, the worse the star rating is. So you could see the fewest points, up to 10 in this case for New York, the most recent cutoffs, and these change all the time, and they always get more and more difficult. You need fewer points in order to make it to a certain star rating, and then going across to 1-star. So generally speaking, and I won't get into much detail, but like a simple, basic, lowest level deficiency, lowest severity deficiency would be a 4-point D level citation. So if you have more than, if you have 3 of them, you won't be a 5-star in New York. You'll be a 4-star, and that would include, the complaint-driven or the self-reported incidents, and any deficiencies that result from that get included. So you could have a perfect survey, but if you have 3 complaints and each one, this wasn't right, we're going to assign a D level deficiency, you'll end up with less than that. Other interesting point is this is all like by state. And so in other states, they have markedly different sort of working environments. In California, for example, the cutoff for a 5-star could be actually higher than 60. So, you can have 10, or in this case, I guess 15 for level D level deficiencies and still be a 5-star, because it's all by state, and then they assign sort of the star ratings to make sure that a certain percentage fall into each category. So it's weighted, and it's different across states. So the quality measures are different, right? And then the quality measures are more points means more stars. And those thresholds adjust all the time, and it constantly gets harder and more competitive. And there's 9 long stay measures and 6 short stay measures. And you could see the totals that are required for a 5-star in each category. And so if your combined points across all 15 measures is a minimum of 1456 at this point, then you're a 5-star. And if not, again, there's difference going down. So the long stay measures are these. These are the 9. Some are weighted 50% more than others, i.e. the ones on the bottom that have 150 points possible, and others 100. And these 2 are also, you're competing against everybody else. And so they assign the top decile in each quality measure nationally. This is not by state, but nationally will get the full points. Let's say 100 points. Well, let's focus on what things we're going to talk about, the ones in highlighted. So for antipsychotics, residents receiving antipsychotics is generally a bad thing. So those that have the top decile performance and the lowest percentage of residents on antipsychotics would get the 150 points. And then for each decile, it's 15 points. So 15 times 10 is the 150, which is why you have 150. And for the 100 points, it's the same concept. It's just 10 points each. So we're going to discuss in more detail here, and Ruth, when I hand it over shortly, is going to talk about those measures in detail, the antipsychotic use, which I'll tee up first, and then hospitalization and emergency department visits. Obviously, generally speaking, concept being we want to avoid unnecessary both hospitalizations and ED visits, and so we measure those things and report on them. On the short stay, same thing. There are different measures. We're going to discuss these similar overlapping ones, but it's also, new or worsened pressure ulcers, folks that, have deep decrement in their functional independence, because the whole point of the short stay is to get well and go home. So you want to help people get better, and this is those that don't. And to help people get well and go home, you want to measure also how successful are you at getting people home, the whole goal of short stay. So remember, the quality measures are broken into long stay, short stay. They're different people here for different reasons, wildly different sort of expectations, and the measures are different as well. So on the antipsychotic quality measure, this is the data that we pulled, to refresh this most recently from CMS website. It's the percentage of short stay residents who got an antipsychotic for the first time, and it's a percentage of long stay residents who are on an antipsychotic. These data are our data. Ruth, if I can toot her horn, does an exceptional job as our senior medical director, keeping a very close eye and looking all the time at opportunities to minimize the use. And so, in short stays, we're starting it at 0.1%, and you can see the national and the state averages there. And in the long stay residents, we're about 5%. You can see the national and New York averages there around 14, 13%. So this is an issue because, as you know, and you've had other courses with extensive information, I'm sure, throughout the last several days, basically what we're trying to do is manage the behavioral and psychological symptoms of dementia, which is prevalent up to 90%. With the severity of dementia comes more prevalence. And in long-term care, it's the number one reason, and the majority of the time, why people end up coming into nursing homes, because of the difficulty managing the behavioral disturbances. There's a lot of medications. Again, I'm not going to go through them because you've had information about them and will. But all these medicines are often used. They may not be directly indicated, but off-label, but they're used. And the bottom line, in my view, and Ruth, is basically that they don't work, right? And we use them for lots of reasons and get pressure to use them by families and others, but they really don't work. So this became an issue all the way back in 1987 with the piece of legislation that said, hey, we think we're overusing antipsychotics in nursing homes. Let's try and address it. We'll establish a dose reduction, right? And sort of non-pharmacological management, and see what we can do. There was a decline. As you can see, the numbers back then were significantly higher. About 35% of residents in long-term care were getting psychotropics back then. There was a lot of off-label use. And look, 15 years later, 2001, I mean, a modest decline, but you're still at 27%. So more efforts, right? So 2003, you guys know there was, a lot more use of atypical antipsychotics. We felt that they were safer and better, but sure enough, they have a black box warning too, and increase absolute mortality, right? 60, 70% increase in mortality when you're using them to treat behavioral manifestations of dementia. So we put a black box warning on it in 2005, the FDA, and extended that, like I said, to the typical antipsychotics as well, like haloperidol. And then it continues with different OIG reports, different sort of percentages. But what you can see on this slide is the kind of prevalence persisted and kind of stabilized around 15%. So even 8 years ago, the national prevalence of antipsychotic use in nursing homes was 15%. And today in 2025, that national average is 14.5%. So not a lot of incremental improvement, although it is achievable. I mean, just look at what Ruth has accomplished at the New Jewish Home with 5%. And then there were new regulations introduced again to try and push on gradual dose reduction, trying to really rein it in. The last effort, and then I want to move over to Ruth because I'm talking too much, is schizophrenia coding. The industry operates entirely from a defensive posture because, unfortunately, the way CMS sort of views the industry is like we use sticks to regulate. So we use threats, citations, deficiencies, penalties, monetary penalties. That's the only way to get people to act right, as opposed to working with us partners. But that's a whole nother story. But this is a good example of that. So what they're saying is, we think people are gaming the system by saying that patients who are on antipsychotics have legitimate reasons, right? Like schizophrenia, Huntington's disease, Tourette syndrome. They're excluded because, if you have schizophrenia, you should be on an antipsychotic. But they noticed that the coding of schizophrenia in the long-term population would just seemed way too high. So they've started to do, only over the last couple of years, very targeted offsite audits, asking for your records, and then saying, hey, this patient's on an antipsychotic. You say they have schizophrenia. I don't see any evidence in the chart that they do. And the penalties are quite severe. If you flip down to the bottom here, you end up, no matter what your quality score is, like right now we have a 5-star quality rating, and we have about a 500-point buffer into that 5-star, quality zone. But if they say you have an inaccuracy in your coding in this case, in this audit, your quality score will drop to 1 for at least 6 months. And then, they'll remonitor an issue and there could be penalties too. So meds don't work. You get penalized. They're working to make sure bad actors aren't gaming the system. So what can you do? So I'll turn it over to Ruth.
Okay, thanks, Jeff. And thanks for having me. It's good to be here again to talk about nursing home quality, which is what I focus on pretty much most of my time. And we're going to talk about the antipsychotic quality measures and the hospitalization quality measures. The antipsychotic quality measures count toward 2 of the 15, and the hospitalization count toward 4 of the 15. It's long stay and short stay hospitalization and long stay and short stay emergency department visits. And that's a lot of weighting toward these 2 measures. And there are also measures that medical professionals have sometimes more control over than some of the other quality measures, which may be more nursing driven. And like Jeff said, we have had tremendous success in our nursing home in the antipsychotic measures. It does take a full team with multiple disciplines, but the orders are written by the medical providers for Haldol, risperidone. And so if the medical providers are on board, then it's easier to maintain control on this measure. And you can't just remove antipsychotic medication and offer nothing in support because, like Jeff said, these nursing home residents are coming to the nursing home primarily because of issues with behavioral and psychological symptoms of dementia. Sometimes it's very hard to manage at home, and the hope is that they can be managed in the nursing home, but the behaviors don't go away. And so something needs to be done to help these residents aside from prescribing. There are many options. The first one I'm talking about is a Comfort Matters program. It's a program that you can register with, and they'll provide training and certification. The program is based on understanding the personal needs of the nursing home resident and doing person-directed practice with the belief that every behavior that they have is a type of communication, and it's incumbent on the staff to understand what they're trying to say, and giving the staff empowerment to understand the residents and work with them. Other important management for behavioral and psychological symptoms of dementia are listed here. They're all important. Evaluate for a medical cause. We can never skip this one. Anytime you skip it, it's always going to have been true. So in the cases that you don't check a urine culture, it's always the UTI, but there can be many medical causes for someone with dementia to start having behaviors or to have increasing behavior. Music therapy, pet therapy can be very beneficial. Person-centered care, evaluating for pain, sometimes using nonverbal pain scales like PAIN-AD, making sure that their sensory impairment has been reduced, give people their glasses, their hearing aids, mobility devices, make sure that they're on a proper scheduled toileting so they aren't uncomfortable, manage their thirst, hunger, and living environments, make sure that staff knows how to communicate, and consistent assignment whereby the same staff, mostly the CNA, is assigned to the same resident so that they can build a rapport and understand the residents better. Here's some research about some of these interventions. There's a program called Music in Memory, where a resident will get a headset with music that they chose, that they listened to in their adulthood, and the music will be played for them during times that can be challenging, like during care. This program was shown, this article is published in JAMDA, to show reduction in psychotropic medications, including antipsychotic, anti-anxiety, antidepressant, reduced behavior, reduced depressive symptoms, pain, and falls. It's a really lovely program, and we've used it at New Jewish Home. And we have a slide and a little video to show you how the program had an effect on a nursing home resident. So I'm going to play that now.
So I'd rather have that for him.
We first see Henry inert, maybe depressed, unresponsive, and almost unalive.
Henry.
Yeah.
Henry.
Yes, sir.
I found your music. You want your music now? Let's try your music, okay? And then you tell me if it's too loud or not.
Then he is given an iPod containing, we know, his favorite music. And immediately he lights up. His face assumes expression. His eyes open wide. He starts to sing and to rock and to move his arms, and he's being animated by the music.
And he used to always sit on the
So I love that video because it shows really how somebody can change their behavior, or a staff can help a resident without using medication. There are other options and things that can be tried. Some of them are as big as an entire model of care, an entire building structure. An example of one is the greenhouse model, which uses small group units clustered together, so people living there can have a communal life together with a group of people, small group of people that they see every day, and have a communal dining area. Greenhouse model has shown some strategies for reducing unnecessary medication use, and try to train their staff to break out of the prescribing patterns, and this program has been successful. Another way to approach prescribing in nursing homes is deprescribing, which there have been lots of publications and ways of doing deprescribing, like in the last 5 or 10 years. At Jewish Home, we've tried several different programs for deprescribing. All of them have been successful, and this article shows that it can be done. This was an article published about deprescribing in Australian nursing homes. And the goal was to exclude those patients that, as Jeff said, absolutely are on label for antipsychotics, schizophrenia, bipolar, Huntington. And they gave an antipsychotic deprescribing protocol to those nursing homes so that the nursing homes could feel safe in what they were doing and understand exactly how to deprescribe, which is usually done by decreasing by a small percentage every week over several weeks. And they were able to reduce the number of nursing home residents by 81% and didn't see any worsening in behavior, which is similar to what we have done at Jewish Home. Sorry, just slides are going a little bit slow for me. So the antipsychotic measure can be one to work on. It can't be substituted for nothing. Staff needs to buy in and understand how to care for the residents, and the prescribers need to understand how deprescribing can be done in a safe way. And when these approaches are used, then the numbers can be dropped, but it does take a lot of effort to do. It is absolutely in the best interest of the resident to come off medication that can be harmful, even cause death, and ultimately doesn't benefit them in many ways. So hopefully that was helpful. We're going to move on to the hospitalization quality measure. Again, it's one of the measures that's very important for the entire interdisciplinary team, but has a lot of control by the medical team and how medical incidents are managed. And if they're managed on time and with the right approach, which I'll go over some, hospitalization can be brought down as well. I'm going to talk about the CMS 5-star quality measures and approach to that, but I also wanted to mention that there are other programs that incentivize nursing homes for reducing their hospitalization rates. This is a separate program from the 5-star. This is CMS's SNF VBP. It's facility value-based purchasing, which is a SNF incentive payment program by CMS. And CMS will rate nursing homes and then give them higher reimbursement if they're performing well. So there used to be one measure in the SNF BBP, which was readmission, which I've already said counts toward the 5-star and 4 of the 15. And this year, CMS is also counting in the measure hospital readmissions specifically associated with healthcare-associated infections, total nursing staff turnover, and total nursing hours per resident day. And if a nursing home performs well in these 4 measures, then they will receive a multiplier for their normal Medicare rate to get even more money. So they'll be financially incentivized to perform well here. Jewish Home performed well. This is actually our scorecard that we just received that shows that in 3 out of the 4 measures, we're performing better than 98 or 100% of SNFs nationwide. And it's really important to do well for the residents, for the nursing home, and it also helps us with the bottom line. So I'm going to talk about how we approach hospitalizations. These are from 5-star back to 5-star right now. The hospitalizations per 1,000 long stay resident days is the measure, and it's a rate. So our rate is 0.76 with a national average about double or even higher. And the second is the percentage of short stay residents who are rehospitalized after a nursing home admission. So this is talking about nursing patients who are discharged from a hospital to a nursing home. And then what percentage of those go back to the hospital within 30 days? And the national average for that is 23.4%. New York is 20.5%. And at Jewish Home, we're holding at about 11.7%, which is excellent. And we're in the top ranking, ranking for that. There are many factors that go into hospital readmission. We're calling some of them inappropriate. And unfortunately, CMS doesn't really give you a pass if the readmission was appropriate. So we all know that there are many things that nursing home residents or rehab patients have to go back to the hospital for that can't be done in a nursing home. And RBC transfusion is one of those things. Nursing homes aren't certified to administer RBC transfusions, and sometimes people need a transfusion, and so they have to go to the hospital to get it. It's harder and harder to get that done in an outpatient setting. CAT scans, if somebody falls and hits their head and is on anticoagulation and they need to get a CAT scan, you need to send that patient to the hospital. So you can't have your number be 0 on the readmission because you're going to have to send some patients to the hospital. But there are many reasons that people go to the hospital that are preventable or avoidable, and I'm going to go into how to approach that. So for the inappropriate hospital readmissions, all of these things in this depiction can contribute to those inappropriate readmissions. The first being at the top of the picture, inappropriate hospital discharge. So hospitals are also under increasing pressure to discharge patients, and occasionally will do it before the patient is technically ready, unstable, and has to be sent back once they arrive at the SNF. Lack of advance directives. Now, this can happen in many ways, not because a DNR or something like that wasn't discussed, but on the MOLST form, the medical orders for life-sustaining treatment, that hospitals often will fill out for patients and outpatient providers. They skip over the part that talks about hospitalization because it isn't always such an important thing to discuss in a hospital when they're hospitalized. But for us in the nursing home, it's one of the most important parts on the MOLST form that has to be discussed. So if a patient comes to us without having that section on the MOLST filled out, or really not having a MOLST at all, and we don't have time to approach it with the patient or resident because they get sick too soon after they arrive, then they might end up going back to the hospital. Other things that contribute, polypharmacy, not recognizing warning signs of patients getting sick. So you can't approach them and treat them until it's too late, until they're too sick, and then they just absolutely have to go back to the hospital. Nursing homes also could have a fear of litigation. So when patients become very sick, they can become fearful of their own management and want to just get it off their hands and send the patient back to the hospital so that they don't get sued for how they managed. Because we all know that nursing homes are often sued. All you have to do is watch TV to see the numerous commercials trying to incentivize patients and families and loved ones to sue the nursing home. Poor communication and patient and family preferences. So if the patient or the family doesn't trust the nursing home, doesn't understand the nursing home's capability, they can just ask to go back to the hospital. They actually call 911 and just transfer themselves over. And all of these count toward the inappropriate readmissions that can possibly be controlled. It's a lot of work, but it can be done. The triple aim of healthcare is to enhance patient experience, improve population health, and reduce costs. some numbers are that up to 69% of nursing home readmissions are potentially avoidable, and that's where the work needs to be done to identify high-risk patients and do some interventions to reduce the readmission. So what are some of the interventions that can be done? CMS did some work in 2012 with the Innovation Center for initiatives to reduce avoidable hospitalizations. They chose 7 sites and gave them funding. 143 facilities were included in total. And each of the sites had different interventions that they were using to reduce hospitalizations. Some of them include having an RN or an NP provide consistent clinical care. Some of them had more positive outcomes than others. I'm going to show you just one of the sites. On the next slide was the intervention was implemented in Missouri. They collected 3 years of data. It was done in 16 nursing homes, and they had an advanced practice registered nurse on site, a support team, and they used the Interact quality improvement coaches, and they were able to show a 30% reduction in all-cause hospitalizations. When we're talking about the Interact program, this is a gold standard program in nursing homes. Interact is interventions to reduce acute care transfers. It's a bundle of guidance toward the CNAs and the nurses on how to evaluate a patient, how to escalate it to a medical provider, and how to get in there early in order to try and treat and avoid hospitalization. And their initial data showed 24% reduction in all-cause hospitalizations over a 6-month period. This is just an example of an intervention. Another intervention, this is mostly about things that can be done, including polypharmacy and transitions of care. These are numbers from Jewish Home. One of the geriatrics fellows did a project with us where he looked at the discharge transfer paperwork from one of our partner hospitals, and then looked at the chart at our nursing home and looked for medication errors and found that 30% of the admissions that we got had errors in the hospital discharge documents. And so that is a very risky area if the medications aren't done properly, if the discharge is wrong, or if the provider at the nursing home misunderstands or misses something and the medications have an error in it, then that can clearly lead to worsening clinically and then the need to hospitalize. Another intervention that can be done is using protocols to help nursing homes manage their patients, COPD protocols, CHF protocols. These have had varying results in training staff on how to approach clinical scenarios in time effectively to reduce patient worsening in symptoms and the need to hospitalize. Another approach is through the use of telemedicine. Most nursing homes don't have medical providers on site after normal business hours. And really during the day at all, many nursing homes don't have doctors or nurse practitioners on site. They come in from time to time. So telemedicine can be helpful and has had increasing use ever since the pandemic started. This particular intervention had telemedicine coverage on nights and weekends, and they were able to treat the nursing home residents that they were called about 97% of the time. They showed a reduction in hospitalization by 20% for long stay, decrease of 30% for emergency department transfers, and reduction in rehospitalization for post-acute by 21%. So really effective outcomes by being able to use telemedicine to see the nursing home patients after hours when they aren't normally there and do more of a clinical real evaluation to try and diagnose the patient, implement medication management or diagnostics in order to diagnose and treat the patient sooner rather than waiting for the next business day for somebody to come in. So best practices in reducing avoidable hospitalizations are listed here. I'll go through some of them again. No nursing home does it exactly the same way as another nursing home, but all of these can be effective in order to reduce rehospitalization rates safely without increasing morbidity or mortality in the nursing home. Another approach is to risk stratify. So know who your riskiest patients are, the ones who are frequent flyers to the hospital, frequent flyers from home to the hospital and from the nursing home to the hospital. Patients who have multiple comorbidities, patients lacking advanced directives. Know who these patients are, keep a close eye on them, whether it's a medical eye or a nursing eye. Risk stratify and know who the sick patients are in the nursing home. manage the transitions really well. I talked about the errors in medication management. That can be mitigated by a warm handoff. Commonly used is telephone, but chat messaging can be used as well, with the sending team from the hospital to the nursing home receiving team, so that none of the essential stuff that isn't captured in the hospital documentation is missed. Knowing your patients and residents and implementing person-specific interventions, making sure that goals of care are addressed and appropriately done. Don't skip the hospitalization question on the MOLST form. Make sure that the resident has verbalized their wishes about going back to the hospital or not going back to the hospital, so that they aren't sent to a hospital when their wishes are not to go and they die in the emergency department, or worse, in the EMS transfer on the way over. Make sure that you know your residents' wishes and can honor them. Early in-house management of changes. And this is very challenging. It requires nurses to be vigilant, to know their residents and patients, to detect changes early, to report them to medical providers, and for the medical providers to be responsive in diagnostics and in treatment, instead of waiting for the resident to worsen and then it's too late and then they 100% have to go to the hospital. Evaluating root cause analysis. We do this at Jewish Home with every hospitalization. We review to see if there are any things that can be, that the staff needs to improve on, any areas of education or training or even protocols that can be worked on. You don't know what your reasons are for transferring hospitals if you don't evaluate this and look at them from a further, from a viewpoint where you can spot trends. So those are some interventions that can be done to reduce unavoidable hospitalizations in order to keep nursing home residents in the nursing home. If they're there for rehab, they really can't rehabilitate if they're constantly going back and forth to the hospital to receive their care. If they are well enough to receive care that the nursing home can provide, and nursing homes have really increased the ability to care for patients. Most nursing homes have the ability to provide IV medications. They have stat x-rays that can come in on wheeled devices, dropped off by trucks. They have on-site labs. Really, most of the diagnostics and treatment that can be done in a hospital can be done in a nursing home as well. And so it's very important to make sure that you're utilizing all those resources to the best of your ability, and know your patients and know what your pain areas are in the nursing home where you can improve, and then implement interventions to improve, and you can get your numbers down. So hopefully some of this content will help you if you work in a nursing home, and if you don't work in a nursing home, understand where our priorities are, why it's a challenge for us to provide care, why we send our patients back to the hospital when we do, and all the things that can be done to try and improve your quality measures and also therefore improve the care that you're providing. Those are all the slides that I have. So I think we're going to turn it over for questions, and we're happy to take any and all.
Thank you both, Dr. Farber and Dr. Spinner, for a very interesting talk and really some up-to-date evidence in terms of intervention. And so that's one of the first questions that we receive from the participants. In terms of telemedicine interventions and being so effective, are these activities billable?
Yes. The activities before the pandemic were only billable if you were in a rural site or other requirements, but since the pandemic, they have been billable. And so a lot of nursing homes have implemented these programs. They might become unbillable moving forward in 2026, but we're going to see and hope that they continue to be billable.
Excellent. And in terms of that as well, how is that process of telemedicine done in the nursing home? Is that something like a video setup, or exactly, how is it possible?
Yeah. So there are some groups of doctors, or really anyone can do it, who have their setup at home. And then on the nursing home side, somebody in the nursing home will help the nursing home resident connect to that provider by use of some video device. It can be very challenging for the patients and residents that we care for to do that by themselves. First of all, they might not even have the technology. They might not even have a cell phone. They definitely might not have an iPad. So we have to give them a device to use. And also there are some challenges with using the technology. So the nursing home has to have staff that can help the patient. Sometimes they have to stay in the room for the entire visit and also have to give extra information, things that some of the providers might want, physical exam. So use the device to try and visualize, and also get some information from the chart, which the patient can't provide, and the nursing home provider at home may or may not be able to access. In many cases, they have access to the chart. In other instances where they don't, they would have to use the nurse to help relay the information, like what's the medications, what's the weight, things like that. So it can be done, but it requires a lot of support from the nursing home side to help it get done.
Thank you. Our next question, it was very interesting to see kind of the effects of a music program. Is that something that is readily available, accessible to other nursing homes?
Yes. Nothing is free and nothing is easy. And so the music and memory program, when we have run it, requires the nursing home to purchase devices, because not all nursing home residents are going to have the technology or devices, to help upload the music that they want, and then to teach the staff how to charge the devices and use the devices. It's not always easy for staff to use, and then to understand when to apply it to nursing home residents. So it's definitely not something that is, easy, but it's worth it. And any nursing home can do it. Many nursing homes have other types of music programs. Most do, with varying efficacy, but it can be done and it's widely available.
And if I can just add one thing on that, there's a very low tech way that we use this too, and everybody can do it. And first is, like, we recommend everybody coming in have, it's almost like your healthcare, it's your advanced care planning. Like, you should include a playlist of the music that your loved one, who's coming in, loved during their life, and know that. We have in every patient's room and resident's room, an Amazon Echo Show, and you could just say, "Hey, Alexa, play this," right? And the music will play. So it doesn't have to be sort of all programmatic always, and expensive with partners, but there is a real, and we think, great benefit of it. The other thing I'll add is we're also working on a new technology with the virtual reality headset, because we think that could also work to help people with similar managing of the behavioral and manifestations of dementia, by bringing them back to places that they grew up in, places that are calming for them, whether it's hiking out in the woods. And you can get very specific. You can go back to, like, the address of the street where you grew up on, right? Or the park that you played in as a kid. And we think we're going to try and study that with that we need funding to support, to do that work too.
Thank you. Thank you, one, for the presentation today, and two, for really bringing us up to date with new innovations. I really love the idea of the virtual reality experience and look forward to hearing more about it. I thank you both for your time and for sharing your expertise.
It's our pleasure. Thank you so much, everybody. Have a great rest of the day.
Bye-bye.